and to sort out with the common pitfalls is going to do an excellent job with the patient to ensure the patient safety. So this is going to be an interactive discussion among Dr. Parivelvan Rajavelu, consultant surgeon, Sundara Medical Foundation, and he is our founder for the skills format. And about him, so I just want to give a quick introduction. He is a orator. He's a quality person who's a keen interest towards upskilling the nurses, and that's how all the modules, all the courses have been outlined to empower the nurses to voice out in the healthcare. And myself, Stella Townsend, training manager in the skills format. So before getting into the best practice, I would like to give you the basic introduction about IV therapy. As you all know, it's a medicine or the fluid or the nutrition which is given intravenous through the bloodstream, and the action of the medication or the thing which you're inserting is going to have a immediate absorption and the fastest route to deliver the medication and the nutrients. And when it comes to IV therapy, the proper insertion, maintenance, and monitoring are essential to prevent the complications. So here there is a scenario. Imagine everybody, now we are in the hospital in an emergency department. We have received a patient named Mrs. Kumuda, 78-year-old woman, and she is admitted after 3 days where she had a complaint of vomiting and diarrhea, and now currently she is with the severe dehydration, weakness, and low blood pressure. So on assessing her, so I found she is weak, confused, and not very responsive due to dehydration. So now I'm going to call the doctor. So the doctor have ordered to right away insert the IV line for the fluid and electrolytes to help us stabilize for the condition. So now we all know we are the professionals. We're going to select the vein on her hand and then insert the IV. And after a few minutes, there is a swelling at the IV site. As I have said, Mrs. Kumuda is very weak and she's not able to respond properly, and she have not mentioned anything out of her discomfort. She haven't mentioned anything about that. So on next round, going into her room, I found the area where the IV cannulation has been done is very cool, puffy, and there is a sign of infiltration. Dr. Pari, what would you say? What things have went wrong in this scenario?
Yeah, I think several things can go wrong. I think listed that in the next slide. Can you move to the next slide? Yeah. So these are some common pitfalls we see. One is not preparing the patient properly. Here, in this patient, it may not be relevant because the patient is not very conscious. But for a conscious patient, it's very, very important. The second is not selecting the proper site and not providing anesthesia. And I think in this case, the most relevant problem here is probably the nurse did not observe the flashbacks properly. So that's probably, as I think the most, all of you would be, would have agree with me that is probably the vein had a counterpuncture and the fluid is leaking out, into the tissue. And also, not using the tourniquet properly can make the veins less visible, and not having the item set up properly is another cause. And finally, not choosing the correct dressing and not doing the risk assessment. So it's not that, I just like that thought this list. Actually, this questions which and the answers which we are going to do will cover all these points in this presentation. So that's, but if you see that these are the common pitfalls why we fail in IV cannulation attempt. So that's what I wanted to say.
Thank you so much, sir. And what are the key steps in preparing a patient for IV insertion? Because we would be advised to do IV insertion, and we might be missing out some key steps, which is really going to be a problem during the procedure.
Yeah, I think a lot of things are there, but what I wanted to emphasize is in this presentation, we also looked at the evidence. Because IV cannulation is done by everybody. We do it day in and day out. So if I, as I told you, if you ask 100 people, there will be 100 different opinions. But what we wanted to focus in this presentation is that we wanted to look at what is the evidence. No, some of you may say, I want to do the patient sitting. Some of you may say, supine. But the evidence clearly shows that a supine position is the best for IV cannulation because the heart is almost at the same level as the arm. It causes venodilatation, and this venodilatation is very it helps you in your IV cannulation. So that is the first thing. So when you say how would you prepare, first is positioning the patient. Before reading this paper, I used to think that the sitting position was the best one, and also comfortable. I still feel that's more comfortable for the patient because they also feel a little bit in control. But in terms of pure technique, I think supine position is what is recommended. The next is, can you go to the next slide? There are several other factors. So one is a good lighting. So, if you have a sunlit room like this, it doesn't matter, but most of our hospital rooms are quite pretty dark. And so we need to make sure that we have good lighting. Get yourself in a comfortable position. So this is, many times ignored. So this is called as ergonomics. To do any procedure, you need to keep yourself in a very comfortable position. So you can say here again, the patient is in a semi-supine position. But when if you put the patient supine, then they have two options. Either you have to bend down and do it, or you have to have a sort of stool or something to sit down to make yourself comfortable. Most of the time, you won't have the stool with us. So here you have to look at the cultural sensitivity. But I find the best position is actually sitting on the bed and then doing this procedure. So of course, if there's a member of the opposite sex, then you probably have to be very careful about, as I said, cultural sensitivity. So that's a comfort position. Then explain, we already discussed this, and do not frighten the patient, but tell that it may hurt a little bit, but you will do it as painless as possible. Another important thing, we will also discuss this later, is to offer whether local anesthesia before the procedure begins. So this is something most of us don't do, but there is enough proof for this.
So here comes the key consideration for setting up the IV equipment, doctor.
Yeah, I think we spoke about all other things like the external factors, but most important is, as many of you have already told, that you get organized even before the procedure starts. So what is there in the IV cannulation tray? So that is what we need to look at. So next slide. So here is a very good picture where in a tray, what is that is required for IV cannulation. So you have the saline here, and so for the flush and that 10 ml syringe, you can even draw the flush syringe. Many of us use the pre-filled syringes, which are commercially available, but they are expensive. And then you need to have sterile gauze, an alcohol swab for swabbing the skin of the patient, a blunt needle if you want to take medicines, and then the tourniquet, the cannula itself, and then this is called known as the needleless connector. So the needleless connectors are very, very useful. These are about 100 to 150 rupees in cost. But if you put this needleless, you may need it with an extension like this, or you can just screw it on to the hub of the cannula. So this will have a valve which prevents flow of blood outside. So there is no danger of the blood leaking out of the cannula. But at the same time, if you give any medicines or start the IV line, it starts flowing. So this is very useful, especially if it's an ambulant patient. You have to disconnect for the patient going to the toilet or going for investigations. These needleless connectors are very, very useful. And then you have the cannula dressing and a pair of sterile gloves. Here, the other picture, what I wanted to show is preparation. So when you have the sterile gauze and all that, you need to open the wrappers and keep it ready. So because when you're putting the IV line, you cannot be, your one hand will be mostly occupied with putting the cannula. So you should be able to take the rest of the supplies readily, and for that you need to keep them out of the packages so that you can easily take it. So we discussed about ANTT, I think, in the past webinar, antiseptic non-touch technique. So most of the time it is the inner wrapper which is sterile. The outer wrapper is not sterile. It's there everywhere. So you just need to open these partially. Here they've shown as if it is completely out of the wrapper. You can still keep it in the wrapper and open it partially. And you can see the hub of the needle, the cap of the needle is not the hub, sorry. The cap of the needle is not locked, but it is out. So these are all small, small things which make you very efficient. And this helps a lot. And very important is to keep all your supplies when you're starting the IV cannula, on the dominant side. If you're a right-hander, keep it on the right side, so that easily you can take these things from naturally. I find sometimes inexperienced people will keep them on the opposite side, and they'll keep doing this. You would have seen this. It's very awkward. That's because simple thing of not remembering that you should keep all your supplies in the where your dominant hand is. So that goes a long way in setting up the equipment and keeping it ready.
Very sure, sir. Because as you said, most of them know in a hurry when they set up for the IV cannulation. We might fix the trolley wherever it is possible, but that we have to look into as the dominant side is very important for a person who is going to do the IV cannulation. Here again, it is mentioned the dominant side. So that would be like comfortable for the person who is cannulating also. So how do you choose the best vein? That would be a great query among all the professionals who are going to do this procedure.
As of 2025, the best practices, you need to do an ultrasound guided choosing of the vein. Okay. But all of
Okay.
us do not have that luxury. So that's the best practice. They say that, as if at all you're going to do the cannulation, use the ultrasound guidance. There are several other things available like an infrared light and all that. But I think certain simple things will be helpful. Next slide.
Okay, sir.
Yeah. So you need to choose the hand which the patient doesn't use often. That is, again, if the patient is right-handed, make sure you do it on the left side of the left hand of the patient. And upper arm is always preferable. And always start from the periphery. You start from the dorsum of the hand, because straight away if you put a line in the arm or in the elbow, then if that gets punctured, then you actually lost the whole arm, right? Because that is countered. So always go from the periphery to the to the proximal areas. And as we already saw that patient supine is very important, and tapping seems to help. And always select a soft, straight, and largest vein. When you have the choice, go for that. And use the veins in the hand first. I already told you that. Avoid joints and veins close to the bone, and avoid thrombosed veins. This is important. Sometimes it may not be possible to. Can you mute everyone, please? I think there's some disturbance. So, in children, sometimes it's very difficult to get these veins, and so you need to put a splint so that they don't bend the elbow. If at all you're using the joints, you need to use the splint. And very important in patients who are having chronic kidney disease, if they have a IV fistula, or if they are planning to have an IV fistula, please do not use that site for IV cannulation. So these are some simple things which will help you to choose the right vein.
Thank you so much, sir. And there is also another thing. How do you apply a tourniquet properly? Because
Yeah, I think,
applying tourniquet is very important when it comes to IV cannulation, no, sir?
yeah. So there is, can you put that picture? I think I wanted to
Yes.
share with you what no, we used to do in the UK.
Yeah.
We used to tie this in a, a loop. You put the tourniquet around and then put a single knot, single knot like that. So that way, with it's just like when you take the shorter part of the loop, the tourniquet will spring off the hand. This is because as you're putting the IV cannula, the first thing you are supposed to do is to release the cannula. Once you are sure that the cannula is in the vein, you don't want to keep the tourniquet even for 1 second longer. So this is what we used to do in the UK. So I found a picture for that, so I thought I'll share it. Most of us use the Velcro tourniquet. So Stella, how do you use the Velcro tourniquet in your experience?
So after looking at this picture, which is used in UK, it is very convenient when looking on it, because the thing is, like, easily it can be removed. The Velcro, when it comes, like, we have to know, like, if so expert, we can use the one-hander. But when it come to like junior most level or the mid level of nurses who are not much hands on practice, like they have to use their two hand to remove that Velcro. Sometimes it is difficult to remove it off, and that's the part I have found, because before insertion we'll apply the tourniquet, we'll find out, figure out the vein where it is, and then after that, inserting in a while, then we have to remove it in between the same way. But the Velcro part is going to be tough, but still we are like managing with this.
Yeah, I think most of the time we don't have a tourniquet like this in India without
Yes.
Velcro. Most of the hospitals have with Velcro, and these Velcro come with different strengths. Some of them
Yes,
will, easily come off. Some of them, are very sticky.
with
So
too much adhesive.
yeah, so we need to choose the Velcro which can be easily pulled. I think small things, but I think these also matter.
Here comes a. Is local anesthesia more painful than IV cannulation itself? This is the query among most of the patients.
I think you should put this as a poll question, yes or no, so that
Definitely.
everyone could have answered this. I am, very. I don't know if any one of you had an IV cannula in your hand, then definitely you will say yes, right? So, but most of the time when I say why don't you give local anesthesia, this is the argument. They will say that giving a local anesthesia is more painful than IV cannulation. That is why I don't do it. But I don't think it's true. Go to the next slide. And there is enough evidence. No, I don't want you to take my word for it. So, no, the answer is no. Local anesthesia is not more painful than IV cannulation. And it has been proven by many studies. It improves the patient comfort and reduces anxiety. Because if you tell, I'm going to give a small injection which will numb the area, and therefore you won't have any pain when I give you the, when I put the IV cannula, people are more relaxed and it'll be more cooperative. I think, this is something which we need to integrate in our practice. I don't think 95% of the time we give local anesthesia for IV cannulation. You may say it's more painful, or you say you don't have time, some excuse, but we don't do it.
Yes.
And I wanted to show you how in children or even in adults we can give the a mixture of anesthetic which will quite effective. Next slide. So this we practice, we used to practice it in anxious patients in children, but now we can do it for in most of the patients. Only thing it needs, especially pre-op patients whom we can plan the IV cannulation. You have to apply this local anesthesia. It is a mixture of lidocaine and prilocaine. Trade name is Prilox. I don't get any money from them, but this is the one available here in India. You need to spread it thoroughly. Choose the vein which you're going to cannulate. And you can choose, if patient, you can choose both the arms and spread the local anesthetic cream evenly, and then put these adhesive on top so that it keeps in place. Leave it for an hour. The skin is completely numb. And this is something all anesthetists should do, because it is a planned surgery. Then definitely you can give the order so that it is done in the ward, and when they come to the theater, you can do it painlessly. So this is something I wanted to share. This is a practice we do in our hospital.
A great step-by-step guidance towards how to apply this on. Still in India, I think most of them are not using this local anesthesia. But after this webinar, it would be a great insight for everybody. So who are not getting of this practice, they can get into this practice right away. And so I would like to ask you, because we used to say the flashback must be ensured during the IV cannulation. Can you give us a difference between what is a primary and secondary flashback?
Yeah, this I learned after I stopped putting IV cannulas. Nobody taught me about primary and secondary cannulas when I was a junior person, doing the cannulations almost, day in and day out. So let me explain that. Next slide. So first fact to remember is the tip of the needle is longer than the tip of the catheter. Very, very important. You got to remember that. I mean, all of us know, but at the time of cannulation, you need to remember that. The tip of the needle is slightly longer than the cannula itself. So that is the whole logic behind primary and secondary flashback. So that you need to know. Next. Now, what is a primary flashback? So primary flashback happens when the needle has entered the lumen of the vein, but not the cannula. So when you put the cannula at 30 degrees into the vein, as you can see in this picture, when the needle enters the vein, you will get the primary flashback, or what is known as the needle flash. You have the flashback chamber in every IV cannula. So this shows that you have entered the vein with the needle, but not with the cannula. So many people, especially people who start, make the mistake of withdrawing the needle. So this is the mistake. After the primary flashback has happened, you withdraw the needle thinking you're in the vein, but actually the cannula is still outside. And then when you try to advance it, the cannula will keep bending because the cannula is not there inside the vein. So remember the needle flash. Don't say primary flashback. No, that it confuses. So call it the needle flash. And the needle flash, when it happens, you have to advance the cannula another 2 to 3 millimeters in the same angle, and then you will get the secondary flashback. Go to the next slide. So secondary flashback, as you can see in the picture on the right, the cannula has entered the vein, and therefore the space between the needle and cannula will also be colored red. So that is the secondary flashback. So very important, the flashback chamber is only to alert you that you have entered the vein with the needle. Whereas the secondary flashback, when the blood flows around the needle into the cannula, that is a secondary flashback. And that shows that the cannula is inside the vein. Now you depress the angle to about 10 degrees or even less, and then withdraw the needle and insert the cannula. Okay, the action is like this, right? So you will withdraw the needle and insert the cannula. So only after the secondary flashback happens. So this is very, very important to know. And not many people actually teach us. They expect us to just see, see, this is how I'm doing, because they want to feel great, right? They will do all those very nicely. They won't tell us about the secondary flashback, and we will fail because we are focusing on the primary flashback. So the secret is out, like all the magic tricks. Sometimes you get these YouTube videos, how the magic is done. So now you know how the magic of getting the vein into the vein, getting the cannula into the vein all the time. This is something which you need to know.
It was very, very clear, doctor. And coming to the dressing, so what factors influence your choice of dressing?
Right. Let me ask you, Stella, what is your choice?
Yes. My choice is like depending on the department where I am. So for example, depending on the patient, to be very precise, if that patient is going to be like 24 to 48 hours, then I would prefer to give them the non-transparent dressing, because this doesn't involve much of cost involvement for the patient, where the patient is going. For example, the patient is admitted in the daycare with 1 day procedure. I would prefer this dynaplast, which is called as like non-transparent dressing. And then, if the patient is in ER, come for the specific treatment and they're going to get discharged, no point of giving them the transparent dressing. So when the patient is coming to the ER, and I'm sure that patient is going to convert as the IP patient, going to stay with us for more than 3 days, then I am going to give the transparent dressing for the patient. Because this dressing, why I am recommending, because it's going to give us a clear idea whether the patient is very safe after the IV cannulation, whether this patient is going for any phlebitis. In case, it is very helpful in monitoring or observing the patient, during the each round. So this is my preference way of for the dressing in case of choosing the dressing for the patient, sir.
Yeah, I think this is a very, very, this sort of different dressing for different patients is a good thing. And I learned it when I was actually, heading the emergency. This Dynaplast dressing is only about 30-40 rupees, whereas the transparent dressing is 120 or 150, depending upon where you get it. So there's almost three times the, 3 or 4 times the cost of the Dynaplast. So
Yes.
definitely this sort of choosing the patient and putting the dressing keeps the cost down and also serves its purpose. As you rightly pointed out, the why you want to put the transparent is to monitor the cannula for any phlebitis or anything like that. I agree with you totally.
Thank you, doctor. This is the same explanation.
Yeah.
And when to remove IV cannula? Actually, there is a lot of confusion in many hospitals. Depending on their organization setup, they have a lot of queries. When to remove? The guideline says this, and the guideline, some guideline says this. Can you give us a clear idea about that, doctor?
It's controversial. So follow hospital guidelines. That's a very easy easy way to get out of this. But again, what does the evidence show? Right? So
Yeah.
can you go to the previous slide?
Yeah. I'm sorry, sir.
Yeah.
This,
Why
it's
is it
not
not
populating.
go back?
Yeah.
Yeah, here's the one.
Yeah.
See, somehow the NABH guidelines, they say, one thing you have to remember, I know this is just out of 5-week cannulation, NABH does not mandate anything. They only give you certain guidelines, but many people will say NABH mandates. So I know that word is cannot be taken. NABH is only a accreditation body, and it'll point you to certain guidelines and do that. But somehow the NABH assesses, and also the NABH consultants, those who help you to get NABH, have these fancy things. They're saying 72 hours, and it has come into practice. But just go back, way back in 2015 itself, there has been a Cochrane review. As you know, Cochrane review is a meta-analysis. They take 14, 15 articles about the topic, and the power of statistics goes up because of this meta-analysis. They have showed no evidence for routine removal, and it is not beneficial in any way. So they have concluded that a selective approach to removal based on close observation will reduce cost and unnecessary pain, meaning that you have to poke the patient again. Having said that, disclaimer, don't say skills women mandates. Okay, follow your hospital policy, but no, go into your hospital. If you have the influence and power, revisit your hospital policy based on the Cochrane guidelines, and keep your Cochrane guidelines as a reference for your policy. If you change the policy from routine 72-hour removal to selective removal in your policy, keep that reference in that manual and show it to the NABH assessors. This is the reason why we are doing this. So that way you can avoid getting an NC on this. Okay. So, but follow your hospital policy, like conditions apply. No, small
Yes.
asterisk. Yeah.
Thank you, doctor. And what complication can arise with no peripheral venous catheter in situ and IV fluid therapy, and how can they be prevented? Because this is the most concern for all the patients. Even when they get admitted, the moment they hear IV cannulation, they go with all this confusions.
Yeah, I think you're a fit person to do that because you've got a lot of experience in this.
Yes,
Please go ahead. Yeah.
definitely. Thank you, sir. And The complications associated with PVC, everybody know phlebitis, infiltration, extravasation. The difference is like the phlebitis is the vessels are inflamed, the vein is inflamed, so it is like the phlebitis looks like this. The moment, no, and if, for example, in case of extravasation, the vessels is like the fluid which is like irritant drugs. When you give the irritant, that is called vesicant drugs, which is called as irritant drugs. Mostly like chemo drug patients, who are getting this chemo drugs and all, they undergo for extravasation. For that, there is a huge thing, you have to follow many things, like no, you have to be careful in IV cannulation, you have to flush it before disconnecting and after continuing the therapy and all. So that is something out of topic which we can focus later, but I
So
wanted to give you
infiltration, just to be clear, infiltration is just crystalloids,
yes,
clear fluids coming out, and extravasation is vesicant fluids. That's what you're.
vesicant fluids. Yes, sir. Yes.
Okay.
And
Okay.
phlebitis, so, yeah, thank you, sir. And the phlebitis, like most of the no, most of the candidates have this confusion, is like, what is the difference between these three? Phlebitis is, to be very simple, the damage, no, the inflammation in the vein, the infiltration, extravasation, the fluid is coming out of the vessel and it is like filled around the tissues, and that is this. And hemorrhage is like the vein is itself got ruptured. So the patient hand looks like this. If the patient hand look like this hemorrhagic where the reference image have been given, don't call it that as a phlebitis. You should know to know differentiate what the patient is actually undergoing for. So this is about this, the complications, because mostly the patient will be having the infiltration or extravasation, that will be documented as the patient is having hemorrhage, or the patient is having phlebitis, they would say it is a hemorrhage, or the patient is having hemorrhage, they will document that as a phlebitis. So that is a different.
How do you
Uh, so
monitor this?
the monitoring is like, for the intravenous catheter, we have the visual infusion phlebitis score, VIP score. So soon after the IV cannulation, for this patient, you have to maintain this chart. So for this chart, you have the score of 5. So where the patient have different category, no signs of phlebitis, the comes under the score 0. The site is healthy, the IV site is very healthy. So one of the following, like if the patient is no complaining when you go for the round, the slight pain is there at the IV side, redness near the IV side, then immediately the patient will get the score of 1. Possibility that is the starting sign of phlebitis. That phlebitis don't have to look really swelling, erythematic like that. The slight pain the patient is saying, either the patient might say only pain alone, the redness will not be there, still the patient score will be under 1. And for the score 2, patient will have pain and the redness and the swelling. So for example, it is very easy to look at the patient and to analyze. Patient saying pain and you're looking visibly, the erythema alone is there, score 1. Swelling is also there, score 2. Then all these things are there, and with the induration is there, then is score 3. Automatically the other thing, the patient goes for score 2, resite the cannula. Early stage of phlebitis, don't have to wait till the patient undergoes for induration, that is score 3. So score 2 itself, you have to resite the cannula. So that is like, no, for the score 3, resite the cannula and consider the treatment. Because see, for the score 2, I have said the pain, erythema and swelling, you will resite the cannula. If in case you're going to lately monitor the patient would have undergone for induration, you're not only going to resite the cannula, the patient is also going to have some treatment. And then if you're missed to identify the score 3, now the patient is going to have the palpable venous record with all the symptoms where the patient will have for score 1, 2, 3. So for this patient, you will have advanced stage of phlebitis and you will resite the cannula and you will consider the treatment, and that is going to be something advanced treatment. And if you have missed out all this 4 score and you have seen analyze the patient only at the score 5, the patient is going to have pain, redness, swelling, induration, palpable venous. Together with that, the patient will also going to develop fever. And for this patient, you will initiate the treatment and reset the cannula. That patient is going to have the advanced stage of thrombophlebitis. So earlier, I think very earlier times we didn't had this kind of monitoring tool. So it was very difficult to analyze the patient where they're going. So with the help of this tool, every rounds you conduct with the patient, you go monitor the patient, listen to the patient what they're saying and observe visually you observe what is happening with the patient, and you can score out and you can prevent the patient from the thrombophlebitis. So from the score 2 you can prevent that. So that's how for the IV, sir. And about the extravasation or the infiltration or risk assessment, the same like thrombophlebitis, this is a simple tool. Like you will have the grade 0 if the patient is not having any of the symptoms, no symptoms, okay. And if the infiltration is present, you're going to give grade 1. So for that patient, the skin will be blanched, and there will be no less than 1 inch of any edematous in any direction. And if you touch the particular surface, is going to be very cold with or without pain. And for this I would suggest for all the for the candidators or healthcare professional who are working close with the patient is telling no, there is a edema, there is a swelling, there is a pain, go and touch the patient's skin, how it is, whether it is warm or whether it is cool to touch. That is another way to identify what the patient is going for. And if the grade 2 with the skin blanch, with the edema, now it is going to be 1 to 6 inch, and then cool to touch with or without pain. For this case of extravasation, phlebitis is very painful. Extravasation, they may not, it is not mandatory that patient will say pain. Patient will have a swelling but no pain. But you don't assume patient is not having pain, so the patient is not into trouble. Extravasation is the very risky thing where the patient may not feel pain even. And in the grade 3, you can see in the image visually there is a no you can see the image itself which says let me show that. You can see, so grade 1 how it looks, grade 2 like 1 to 6 inches swelling, and grade 3 you can see gross edema more than 6 inches, cool to touch, and the skin tone itself have changed. It will be like the fingers will be minor, and this the way the forearm is looking very swelled up, and how it
Stretched,
looks
and the
very
skin
different.
is
Yes.
stretched. Yeah.
Yes, stretched. And then no possible numbness also would be there. The patient might say, if you touch, two things is there. One is like you can feel the temperature of the skin, and even one thing, when you pinch or you touch, they might say, I don't feel anything. You're touching, I'm not feeling anything. So that is the possible numbness. And for the grade 4, all the things, skin is blanched, translucent, the skin is so tight, and you can see the fluids leaking from all these sides, and skin is discolored and bruised, swollen, and edema is more than 6 inches, and you can see the pitting tissue edema. You can touch and it is very hard, and there will be like circulation is stopped, and moderate to severe pain will be there. So in this case this is like they have went to the extreme level, that is grade 4. So for this, what we have to do is like you have to monitor this properly with this particular tool, and you have to analyze the patient in the grade 1 itself, and you have to start the treatment immediately.
Yeah, that's interesting. I think infiltration tool is not being used widely in many hospitals. I think that's
Yes.
something which we need to keep
Yes,
using.
doctor. Usually we'll use only the VIP score. The moment we listen like IV cannulation is done, VIP score chart is there in the patient document. But this infiltration for this, we don't, most of the hospital doesn't use any tool. But this tool would be great to use. Okay,
Okay.
doctor. How to be successful in IV cannulation?
I think there's a reason you put the success in capital letters.
Yes.
I think success again is a mnemonic, but it's a very useful one. Again, as I told you, when I was learning to do IV cannulation, when I was a house surgeon, not even know which needle to use, these things were not taught to me, and we made so many mistakes, and actually the patient suffered. Right. So this is a very, very useful mnemonic. Can you go to the next slide? So success, success. Unfortunately, many of us will misspell this word itself. It has got two C's and two S. So first S stands for skills and selection. U stands for understand and prepare. C stands for consent. The next C stands for cleaning the site. E stands for escalation. S for securing the cannula, and the other is for signing and document. So let me now take you through what we mean by this in the next slide. So there's a lot of information in this slide. So Stella, can you just put the your pointer on the S so that people can focus on that? Yeah, S, the first S. Yeah, that's it. Okay, this S stands for skill. So what is this? First, ask yourself, are you skilled to do this procedure? If not, ask for help. Okay, very basic. And sometimes, it is not that you may have the skill, but actually the patient may be a difficult patient in the sense, they may be obese and they may be, having no veins visible. So if that is something which is a challenge for you, ask for help immediately. And selection. So do we start the line IV or peripheral? It depends on the duration. Anything beyond 7 days, central line is better. And the type of infusion. As Stella pointed out, if it is vesicant or if it is hyperosmolar, like total parenteral nutrition and things like that, you need to give it central. Otherwise, if it is just crystalloids for a short period, less than 7 days, then you can choose the IV. So that is the skill and selection. S stands for that. The U, you can see on top, is to understand. What do you understand? You understand first the patient's condition. Is the patient, so in failure, in the sense, is they in shock? Then it is urgent, and you have to put the largest, cannula possible, size cannula into the largest vein possible. The next is understand the condition of the veins. Some of the patient may have very thin veins, which will counter very easily. Some of them, the veins may not be visible, or patients who had ICU stay for a long time, they come back, immediately for readmission. You may not find any veins. So the condition of the veins and the condition of the patient, you need to understand. With this understanding, you prepare the equipment, okay, and get support. Support means both technical. Now you can get somebody who's more, technically having more technical expertise than you. But in the pediatric age group, also get the support of the family, or even in adults. Sometimes some people have fear of needles, needle phobia. So if that is there, then you need to again get the support of the family. So U stands for understand and prepare. Now we're coming to the first C. Very simple. C stands for consent. So you don't need to get a written consent. A verbal consent is more than enough for IV cannulation. The second C stands for cleaning the site. So you need to clean the site if it is peripheral IV cannula with alcohol. If it is a central line, you need to use chlorhexidine swab. So that is cleaning the site. Then we come to the E, very, very important. Escalate. What do you mean by escalate? You stop doing what you do and call your senior. So that is known as escalation of care, right? So escalation, when do you escalate? Even at the first time, when you have seen the patient and you see only less than 2 accessible sites, then you call somebody who's experienced, or use an ultrasound to put this. Or no veins are visible or palpable also, you got to get someone who's experienced and preferably do it in the ultrasound guidance. But if you have tried and you have failed 2 times, stop. Don't keep on poking the patient. The most common complaint about nurses to or junior doctors to the admin is, I know this doctor came or this nurse came and keep poking me, and on and on. So have a policy. If there is more than 2 unsuccessful attempts, you have to escalate. So that is E stands for escalate. Then again, coming to the S, before the last S is secure. So secure, we already spoke the need for transparent dressings if you want to monitor the phlebitis. But if the patient has got a short stay, then you know that they're going to discharge them in 24 to 48 hours. You can use non-transparent dressing. Very important point is when you're putting the dressing, prevent pressure from the PVC hub and tapes. The hub which is there, so that will usually press on the skin here and will cause a pressure sore. And sometimes, if you put the tapes too tightly, that will reduce the blood supply to the skin and there may be blisters. So blisters happen only when you pull the tape too much and put it down so that the skin gets blanched. So that you should avoid. Okay, so avoid pressure. So that is the, and the last is signing and documenting. So you write the date of cannulation, the time of cannulation, the site, which size cannula you used, the number of attempts you made to put that cannula in, and the name of the person who inserted the cannula. All this should be documented in the notes. And on the cannula itself, on the dressing, you got to write the date and your initials. Don't sign. Nobody, the patient doesn't want your autograph, right? It should be visible who put the cannula in, right? So date and your initials should be on the site of the cannula. So that is the pathway or the road to success for a successful IV cannulation. Pun intended.
So this was really very great. I think most of the participants were very interested in the success method because I can see all the emojis running on the top of the screen.
Yeah, I
So
think this one slide is, the most important slide in today's presentation, I think.
yes, of course, sir. And yes, sir. What are the key takeaways for IV insertion?
Go over, Sila, you can finish this off. Last two
Yes,
slides.
sir. Sure, sure. So the key takeaways, as sir have already explained us, no, the common pitfalls, no, look into that. That is very important. When we avoid all these common pitfalls, it will be like we can avoid the IV site issues. So not preparing the patient properly. So what we have to do, we have to prepare the patient priorly and select the proper site, and not providing the anesthesia is another common pitfall. So we have to start using anesthesia, and that again depends on your organization decision on this. And not observing the flashback, I think the clear idea about what is the primary flashback and secondary flashback has been explained by the doctor. We can start implementing that when we are doing the IV cannulation. And then not using the tourniquet or not using it properly. Tourniquet should be appropriate, and tourniquet is like not using it properly also will not help it out. So that we have to look into it. And not setting up the items properly. So we have to set up the item. So ready ourselves when we get the order for the IV cannulation. We have to prepare the trolley, and we have to think from starting. So starting is like you're going to do the skin preparation. So the alcohol swab, first your hand hygiene, the hand rub is ready, alcohol swab is ready. So step by step you just figure out what you have to set up. And then not choosing the correct dressings, that is again. So don't put the patient into no unnecessary cost involvement. You know how long the patient is going to be. If the patient is going to be 24 hours, or within that time they're going to discharge, so no point of putting the transparent dressing, which has a huge cost involvement. If the patient in the daycare and ER, or the patient is going to be shorter period of time, not more than 3 days, then you can obviously choose the non-transparent dressing, that is called the dynaplast method. And the last thing is like not doing risk assessment. So risk assessment is very important, where I said like VIP score is very important. Equally, the risk assessment for the extravasation is also very important, because most of the patients, we have all kind of patients who are coming into the healthcare system. Not only the patient with normal fluids, we have onco units. You all have to be start using this kind of risk assessment tool for the extravasation, where the most of the patients are more prone to get to it. And best practices is about the success. So this is very important when it comes the best practice. It's not the usual current practice what we discuss in skills format. It is always about the best practice. So as sir said, the S stands for skills and selection. How we are capable, you are competent enough to do the IV cannulation, and you should know which vein you're going to select. And U is like understand and prepare. And C is for consent from the patient, verbal consent. And C is for clean the site. And E is for escalate that what you're doing. And S for secure after the IV cannulation, and what kind of securement you're going to do. And S stands for sign and document finally, that it is a legal part of thing. You have to document either in the IV site on top of the patient dressing, and it has been clearly mentioned what you're going to document there. And in your health record, you have to document what you have done with the patient, which size of cannula you have done. And this is all about. Thank you everyone.